Hello everyone, my name is HUANG Ruibin. I'm a radiologist from the First Athletic Hospital, Shantou University Medical College. Welcome to the medical imaging class. Primary intracerebral brain tumors account for approximately 2/3 of all brain neoplasms, whereas the remaining 1/3 is made up of metastases. As a group, gliomas are the most common brain tumors and include astrocytomas, oculodendrogliomas, ependymomas, and choroid plexus tumors. Astrocytomas account for approximately 80% of all gliomas and are the most common supratentorial tumor in all age groups. Today we will discuss the diagnostic imaging of astrocytomas. As you may remember, astrocytoma begins in cells called astrocytes that support nerve cells. Astrocytoma can be a very slow-growing tumor or an aggressive cancer that grows quickly. Grade of astrocytoma determines clinical prognosis and treatment options, and medical imaging can be helpful. At the end of this class, students are able to describe the typical imaging findings of common types of astrocytomas. The symptoms that patients may have are decided by the location of the tumor. They usually have headaches, nausea, and vomiting, and sometimes a seizure. Other symptoms include mood or personality changes, weakness, speech problems, or blurred vision. Any of patients with these symptoms should see the physician or neurosurgeon and have a CT or MR scan as soon as possible. Astrocytomas are graded based on pathological features. Different grades of astrocytoma, grade 1 to 4, have vastly different patterns of behavior. Grade 1 tumors tend to be very benign and more common in children, while grade 2 are slow-growing tumors in young adults, who frequently present with a seizure. Grade 3 and 4 tumors are more common in adults with more aggressive behaviors and growth patterns. This table shows different features of different grades of astrocytomas. We will just discuss the typical imaging features of common astrocytomas in this section. Pilocytic astrocytoma. This benign World Health Organization (WHO) grade 1 tumor occurs in the cerebellum, optic pathway, optic nerve, chiasm, thalamus, hypothalamus, and brainstem pons. It is the most common posterior fossa tumor in childhood. It is a thoroughly growing tumor with a very good prognosis. Pilocytic astrocytomas are slow-growing and typically large at diagnosis. In the cerebellum, a lesion in the hemisphere is more common than in the vermis. The classic presentation is that of a cystic posterior fossa lesion with an enhancing mural nodule extrinsic to and causing massive effect upon fourth ventricle. These tumors are usually well circumscribed with little to no edema. In this pediatric patient, a body-right-sized cystic cerebral mass is noted, with an associated enhancing mural nodule laterally within the cerebellum hemisphere. Low-grade astrocytomas. This WHO grade 2 tumor is infiltrated in nature, histologically well differentiated, and demonstrates slow growth with time. The most common location is that of the frontal or temporal lobe. Clinical presentation is generally in the 3rd to 5th decades of life. This tumor may degenerate into anaplastic astrocytoma, AA. Low-grade astrocytomas are poorly visualized on CT because they are often isolated with brain. On MR, they are well-defined, homogeneous, hyperintense on T1 and hyperintense on T2 images, non-enhancing mass lesions with little mass effect and minimal vasogenic edema. This is a patient with low-grade astrocytoma in the right frontal lobe. The tumor appeared typical imaging findings. It showed low signal intensity on T1 and high signal intensity on T2 image without contrast enhancement. Anaplastic astrocytomas This is a WHO grade 3 tumor. Usually evolves from low-grade diffuse astrocytoma, WHO grade 2. It occurs at all ages, most common in 40 to 50 years old. On MR, differentiation from a low-grade astrocytoma and an anaplastic one is less well defined, mildly showing some contrast enhancement. It also shows mild to moderate mass effect and accompanying vasogenic edema. This is a typical anaplastic astrocytoma in the right frontal lobe. This lesion with heterogeneous signal intensity and relatively poor definition of extent is noted on figures A and B. Figure C is a post-contrast image demonstrating heterogeneous enhancement within the lesion. There is obvious deformity of the ventricular system, reflecting mass effect. Glioblastoma is a rapidly enlarging malignant astrocytic tumor characterized by necrosis and neovascularity, which accounts for 12 to 15% intracranial neoplasm, two-thirds of astrocytomas. Common clinical symptoms include seizures and focal neurologic deficits. Best imaging include thick, irregularly enhancing ring of neoplastic tissue surrounding necrotic core, heterogeneous hyperintense mass with adjacent tumor infiltration, vasogenic edema, necrosis, cyst, hemorrhage, fluid, debris levels, full voids may be seen. Superior tentorial white matter is the most common location. Figures A, B, and C show a heterogeneously hyperintense mass crossing the corpus callosum genome with signal abnormality extending into the frontal lobe, subcortical white matter. On figures B and C, in the same patient show a thick enhancing ring of tumor that surround the necrotic tumor core, characteristic of glioblastoma. This table shows some key finding features that usually used to differentiate different grades of astrocytoma. Now let's discuss two cases. These two cases are different grades of astrocytoma. Can you describe what you see on these images in case 1 and 2? Then make a diagnosis for these two patients. Okay, let me tell you the answers. Case 1 is a typical low-grade astrocytoma. This tumor appears homogeneous signal intensity on conventional MR images without vasogenic edema or enhancement. Case 2 is an anaplastic astrocytoma in the right temporal lobe. These lesions show isointense on conventional MR images with obvious surrounding edema. On post-contrast image, it demonstrated heterogeneous enhancement. However, these findings are not specific for diagnosing anaplastic astrocytoma. Other differential diagnoses should be kept in mind when these findings are seen. Now, let me make a brief summary for this session. Astrocytomas account for approximately 80% of all gliomas and are the most common superior tentorial tumor in all age groups. Astrocytomas are categorized based on features noted when they are studied on pathology slides. These histological features lend to different grades of astrocytoma, grade 1 to 4. All these tumors have strictly different imaging appearances, treatment, and prognosis correlating with different WHO grades. That's all for this class. These are useful learning resources for you to reference. Thank you.